So thanks everyone for tuning in to Virtual Grand Rounds. My name is Ben Sheppard. I'm one of the CCFP EM residents. And today I'm going to be talking about use of nitrous oxide in the emergency department. So today we're going to touch on the latest and greatest in what's ostensibly a 200-year-old medication. I'd like to just quickly thank my longitudinal preceptor, Marguerite Bredanis, for sparking my interest in this topic and providing some general guidance. I must say, to be honest, I had rarely used this medication or even considered using it up until this year. However, I subsequently had the opportunity to use it at Alberta Children's and at Banff for some acute orthopedic trauma, and I realized it's quite an interesting medication, potentially highly clinically useful, with excellent pharmacokinetics, and that I probably had been underusing it up until now. And I also realized that I knew almost nothing about it and had basically no teaching about it. So hopefully I can pass on some knowledge from today. So I have no disclosures. I haven't gotten any money from Big Nitrous for this presentation. So here's our objectives for the day. So we're briefly going to review the history of nitrous oxide. We'll discuss the properties of nitrous, its clinical effects, how it works, and how we can physically give this medication to our patients. Then we'll take a dive into the evidence and we'll look at some potential evidence-based applications of nitrous oxide in the ED. And then lastly, we'll look at the safety profile of nitrous oxide. So as we go through, here's a couple of cases just to kind of get your mind going. Ideally, if you could take a think now about how you would approach analgesia, anxiolysis, procedural sedation in these cases, if any, and then we can keep them in mind as we move through the presentation. So you got like a 6-year-old kiddo, he's got a facial laceration, super anxious, hyperventilating when you even hear, he even hears the word suture repair. And then you have an 8-year-old kiddo with known difficult IV access, has required multiple pokes in the past and needs an IV today and super anxious about that procedure. And then you have a 10-year-old female with a displaced distal radius fracture. It's a busy department, so you want to provide excellent procedural sedation and analgesia, but also move the patient through efficiently. And then you have a 42-year-old guy with multiple recurrent anterior shoulder dislocation. This is his 8th time. He's kind of fed up with the whole thing, and he's really just asking you, Doc, can you put in my shoulder for me? So keep those in mind as we move along. So let's take a brief look at the history of nitrous oxide. So nitrous is one of the oldest known anesthetic agents. It was first synthesized in 1772 by this guy, Joseph Priestley, and he called it factitious or dephlogisticated air, as it had to be like artificially chemically synthesized. It wasn't naturally occurring. And then 1800, this Cornish chemist and polymath Humphrey Davy was one of the first people to actually isolate sodium and potassium. He noted the potential anesthetic properties of nitrous and first coined the term laughing gas. Flash forward to the 1830s, and nitrous oxide use remains largely recreational. So they had these things called ether frolics, where basically we traveling demonstrations, audience members would come up and they would inhale like chloroform, ether, nitrous oxide in public demonstrations of the psychotropic effects of these agents. And then in 1844, this dentist Horace Wells is watching one of these ether frolics, and he witnesses a volunteer legitimately injure themselves while under the influence of nitrous oxide. However, he quite astutely noticed that they failed to demonstrate a pain response despite their injury, and then that clicked him in to note the potential clinical utility of this agent. Very shortly thereafter, he quite literally put his money where his mouth was and had one of his own wisdom teeth extracted under nitrous oxide sedation, which he noted to be painless. And then nitrous oxide use was quickly supplanted by more potent anesthetics like ether and chloroform during the American Civil War, because they were more potent, easier to transport, and they were already being made for industrial applications. However, nitrous oxide remained popular in dentistry. And then in the 1930s, nitrous replaces chloroform for labor analgesia as the preferred agent, thankfully. And then throughout the 1900s, nitrous oxide popularity has waxed and waned. It continues to be popular in various settings, including dental offices, the L&D suite, the pre-hospital setting, as well as in operating rooms as a volatile sparing agent. However, talking to our peds anesthesia colleagues, it's falling out of favor for that use due to concerns regarding post-operative nausea and vomiting. And then now we'll see kind of where we're at in 2020. So what is nitrous oxide? So you can see on the screen there, it's a very simple molecule. It's composed of 2 nitrogen atoms and a single oxygen atom. It's odorless or sweet smelling. It's colorless, tasteless. It's itself non-combustible, but it is flammable in combination with oxygen, which is how we deliver it. And it's denser than room air, so it sinks to the bottom of the room. But more importantly, what are the clinical effects of nitrous oxide? So nitrous oxide has some interesting clinical effects. So it has significant analgesic and anxiolytic effects, as well as some sedative and amnestic effects, which are concentration dependent. So at concentration below 50%, you get primarily anxiolysis and analgesia. At concentrations of 50% and then up to 70%, you get more sedation and you get amnesia in a significant proportion of population, but not all patients will be amnestic. Concentrations much greater than 70% are required to induce surgical anesthesia. So if you remember back to anesthesia, the minimum alveolar concentration is the concentration of an inspired anesthetic gas that's required to suppress response to a surgical stimulus in half of the population. And the MAC for nitrous oxide is 104%, and that would only reliably anesthetize half of the population. So you would need hyperbaric conditions to use nitrous oxide as a sole agent for general anesthesia. When patients inhale nitrous oxide, they might feel a sense of euphoria, relaxation, detachment from pain, detachment from their surroundings. They might have alterations in perception of their extremities. They might feel like their extremities are light or heavy. They might smile. They might laugh spontaneously, hence the name laughing gas. So what are the physiologic effects? So this is key for our procedural sedation agents, and nitrous oxide has a very favorable profile. So from a cardiovascular perspective, it's almost entirely hemodynamically neutral. There might be a slight mild direct myocardial depressant effect, which is compensated for by an increase in systemic vascular resistance. And basically all of the studies just show it's basically reliably hemodynamically neutral. It does not cause a respiratory depression in and of itself. And at concentrations of 50% and even up to 70%, airway reflexes reliably remain intact. It has no known effect on the seizure threshold. It may have a mild increase in cerebral blood flow. And from a gastrointestinal perspective, it is known to cause nausea and vomiting in a small but significant proportion of patients. However, aspiration is rare as airway reflexes almost always remain intact. And so how does nitrous oxide actually work? So nitrous is actually a dissociative anesthetic, and similar to a medication that we're all quite familiar with, nitrous oxide functions as a non-competitive NMDA receptor antagonist, and it produces a dissociative state not dissimilar to ketamine. The analgesic properties of nitrous are thought to arise from activation of the endogenous opioid system in the periaqueductal gray matter of the midbrain. And this basically releases noradrenergic inhibitory tone to the spinal cord. And this increases the pain threshold and decreases pain sensation. There are also potentially secondary effects related to GABA potentiation. However, there are a few studies that show that nitrous does not seem to interact directly with the GABA receptor. Most of its secondary evidence from the fact that some of the effects of nitrous oxide can be reversed with flumazenil. So primarily NMDA and endogenous opioid are the theories for how it works. And then how about the pharmacokinetics, perhaps equally key for our procedural sedation agent? And this is where nitrous oxide has a potentially highly favorable profile. So nitrous oxide has a low blood gas partition and a very low solubility, and that equates to a rapid onset of action. So you'll reliably see clinical effects within about 1 minute of administering nitrous oxide. You do see these kind of psychotropic effects come on quite rapidly, but CNS concentrations of nitrous oxide do continue to rise. The time to peak effect is a bit unclear, but most studies use 3 minutes as an induction time if you're using it for procedural sedation. And the time to peak analgesia is a bit unclear as well. We'll look at some pain data, but it likely requires minutes to get peak analgesic effect by activation of the endogenous opioid system. The offset is probably the single best part about using nitrous oxide. So it is extremely rapid in its offset. The vast majority of effects are gone within 1 minute, and residual effects, including side effects, are usually gone within 5 minutes. It has no known direct drug-drug interactions, and it's cleared by the lungs, more than 99% unmetabolized. So you stop administering nitrous to patient, and they just breathe out the nitrous that you've given them. So how do we actually physically administer this medication? So there's two basic administration methods. One is continuous flow, and the other is via demand valve. So continuous flow is the method that's used in operating rooms, dental offices, and in some emergency departments, they have continuous flow systems. So similar to when you apply oxygen by a face mask, you'll have nitrous oxide, which can be blended up to 50% to 70% with oxygen applied by either a nasal mask or a face mask at, say, 8 liters a minute, and regardless of patient inspiratory effort, it just flows across their face. These systems do require a gas scavenging system to prevent environmental contamination and exposure. You can see one of the systems on the left. That's a Quantaflex MDM system that's used in a lot of these studies. And this is not available from the Calgary ED system. The other option is demand valve technology. So you can see the Nitronox system on the right, which also has a bottle of pure nitrous and a bottle of pure oxygen, and a blender, which can be blended up to 50 to 70%. The minority of these do have a gas scavenging device, but most do not. And then, so the demand valve works by a patient's got to have a seal on their face or in their mouth, and they need to generate an inspiratory effort of about 1 to 5 centimeters of water to have the demand valve open and gas be delivered. They can deliver up to 150 liters per minute of flow if the patient makes a big inspiratory effort. I'm not really going to go into the controversy regarding the differences in efficacy regarding continuous flow versus demand valve technology. There's no direct head-to-head studies of which one is more efficacious, but there does seem to be some consensus that the best evidence comes from the continuous flow systems, and perhaps deeper and more reliable sedation can be given with the continuous flow system. That being said, with a tight mask seal and no entrainment of room air, you can get quite good effects and similar effects with a demand valve system, as long as they're not taking any room air breaths or having entrainment of room air. So here's the actual system that we have in Calgary, which is a fixed 50% nitrous, 50% oxygen mixture. It's commonly called Entonox. So I'm just going to talk about quickly how to set this up. So at the adult sites, you can page the ortho techs, and they are able to grab this for you and usually set it up for you. And at the children's hospital, the nurses are able to grab this for you. The regulator may or may not be screwed onto the tank when you get it. So this regulator needs to be screwed onto the tank here. It only works in one direction. So if you screw it on backwards, you're not going to get gas flow, and then you'll have to flip it around. Once that's screwed on, you need to use the wrench to just open the valve at the top of the bottle. And then when you look at the pressure gauge, you should see pressure in the bottle, and that indicates everything's set up correctly. When you look at the patient side of things, you can have delivery via a mouthpiece or via face mask. The mouthpiece requires some degree of coordination and probably makes more sense only in older children or adults, because if they take nasal breaths, they're going to quickly dilute out the effects of nitrous oxide. So it requires some coordination. The mask obviously doesn't matter if you take a breath through your mouth or your nose, you're going to get nitrous oxide delivered. Can be a bit scary for kiddos to have masks on their face, but it's probably a more reliable method. And then the demand valve actually does have some limitations in the fact that you need to generate inspiratory force to have gas flow. So, you know, the literature is a bit wishy-washy about how young you could administer demand valve technology, but probably younger than roughly 4 years old. You just wonder if they would be generating enough force to make the gas flow. And it makes a whistling sound when they're breathing in and out, so you know whether gas is flowing or not. Overall, this is considered mild sedation. It doesn't require a procedural sedation setup. It doesn't require RT, second dot, capnography, etc. So it has many favorable qualities in that respect. So what can we actually use nitrous oxide for? So nitrous oxide is most useful for brief, mild to moderately painful procedures without a lot of post-procedure pain. That is its sweet spot. So one of the best potential applications for anxiolysis and analgesia in combination with local anesthetic is for pediatric lacerations. So many studies have looked at laceration repair as a part of sort of a bundle of care using nitrous for minor painful procedures in the ED, but there's only been a few that look directly at nitrous oxide for laceration repair. So this is one study, looked at 60 children, ages 1 to 16, the average age was 4. They had facial lacerations, and they compared 50% continuous flow nitrous oxide plus injected local anesthetic to injected local anesthetic alone, and none of these children received topical anesthetic. And you can see the usual care group in blue and the nitrous oxide sedation in red. So usual care group found the procedure to be quite painful, pain scores of 8 or 9 out of 10 during infiltration and suturing, and dramatically lower pain in the nitrous oxide sedation group. There was also quite significant difference in the need for physical restraint, 100% in the usual care group, and only about 20% in the nitrous oxide group. So none of these kiddos got topical anesthetic, so there may be less applicability to our setting, where I think most of these kiddos would have topical anesthetic applied at triage. So let's have a look at another study here. This is a 30-patient study out of the emergency department. The majority of both groups here got topical anesthetic applied at triage, plus or minus some injected local anesthetic if the physician felt it was necessary. And you can see no difference in pre-procedure pain, however, dramatically lower pain score during the procedure for the nitrous oxide group relative to the usual care group. And again, less need for physical restraint at about 20% versus 55% in the control group. They also looked at anxiety, so no difference in pre-procedural anxiety, but actually a decrease in anxiety during the procedure in the nitrous group versus a predictable increase in anxiety in the usual care group. So based on these small studies, it appears nitrous oxide probably significantly reduces pain and anxiety during laceration repair, but how does nitrous oxide compare to some of our other agents that we have available to us, like Midazolam and Ketamine, to facilitate laceration repair? So this is a very well done study out of the Annals of Emergency Medicine, looked at 200 children ages 2 to 6 years old and compared standard care to 0.5 milligrams per kilogram of oral midazolam to a 50% continuous flow nitrous oxide sedation to combination nitrous plus midazolam therapy. All these kiddos got topical anesthetic, plus or minus injected local anesthetic as needed. And when you look across all the groups, the only consistent finding was that nitrous-containing therapies were associated with less distress, higher suturer satisfaction, faster recovery, less need for restraint during suture removal, so potentially less traumatizing for the children, and there was no added benefit of midazolam over nitrous alone. So how about nitrous versus ketamine? So this is another emergency department-based study of 30 children, ages 3 to 10 years old, undergoing laceration repair. And they were randomized to either receive nitrous oxide at 50 to 70% versus IV ketamine at 1 milligram per kilogram. And there was overall no difference in pain scores. There was no difference in parental, nursing, or physician preference. But children receiving nitrous oxide were less sedated and recovered more than 20 minutes faster than the ketamine group, with less adverse events. You can see the graph on the left shows a shorter net sedation time and a much faster recovery time in the nitrous oxide group. So I think nitrous oxide, despite small studies, has consistently been shown to be beneficial for analgesia and anxiolysis during pediatric laceration repair. And it might be as good or better than some of our other agents that we have available to us. So I think it follows naturally into looking at venous cannulation. So IV starts are probably the single most frequent, painful, and anxiety-provoking procedure that we perform in children. And I think we're all interested in reducing pain and anxiety and optimizing our success rate and time to IV placement. Unfortunately, again, there's limited ED-specific data on this. There's more kind of bundled studies where they look at nitrous oxide for minor painful procedures. So we could maybe extrapolate some data from other settings. So this is a study of 120 non-premedicated children ages 8 to 15 years old in the OR, and they compared topical anesthetic plus oxygen to a 50% nitrous oxide sedation alone to a combination 50% nitrous oxide plus topical anesthetic in patients receiving a 22 gauge IV. And if you look at the bars, you can see the topical anesthetic group in blue, and you can see nitrous oxide group in red, despite no local anesthetic, had significantly lower pain scores and higher patient satisfaction scores. However, the best scores were seen in the combination therapy group with the least pain and the highest patient satisfaction. I think you could alternatively look at this data and say like, hey, EMLA looks like it works pretty well. The pain scores are low, the patient satisfaction score is high. Why should we change practice? And I think I agree with that statement, but I think there's more that can be taken from this. So if you had a kid that needed an IV and you didn't need to, or you didn't feel that you could wait 30 or 45 minutes for topical anesthetic to take effect, if you wheel the nitrous over within 3 minutes, of induction time, you could probably get similar analgesic effect and patient satisfaction with a much faster time to IV start. So that was all comers in an OR setting. How about in an outpatient setting? So this is an open label Swedish study of 70 children ages 6 to 18 years old, and they all had known difficult IV access. They had growth retardation, they had obesity, they needed 2 IVs for a glucose tolerance test, and all of them got topical anesthetic applied. And you can see again, usual care in blue and nitrous sedation in red, significantly lower pain scores in the nitrous oxide sedation group with no increased time of procedure. And then they interestingly looked at their attempts and their satisfaction score, and you can see statistically fewer attempts required in the nitrous oxide sedation group, a median of 2 attempts for 2 IVs versus 4 attempts for 2 IVs in the topical anesthetic alone group. And patients and parent satisfaction significantly higher, 5 out of 5 in the combination therapy group and lower in the topical anesthetic group alone. The same group also followed this study up with a comparison, blinded randomized control trial of Midazolam versus nitrous oxide sedation, and again found less pain, shorter procedure time, and a higher percentage of successful IV placements in the nitrous oxide group. So those are outpatient clinic data, OR data. What about our emerge departments? So again, this is one of those bundled studies looking at nitrous oxide for minor painful procedures, and you can see the title, Limited Analgesic Efficacy of Nitrous Oxide for Painful Procedures in Children. Doesn't look too promising. But when you actually look at their data, their analgesic failures were driven by attempts at fracture reduction with just nitrous oxide sedation. If you look at their laceration pairs, or laceration repairs and their IV insertions, they had a median pain score of 0, and they actually had good pain control for application of plasters and back slabs, but they did have a proportion of patients that did not have sufficient analgesia for fracture reduction. So what are the take-home messages about lacerations and IVs? So nitrous oxide has excellent analgesic effect in combination with topical or injected anesthetic for laceration repair, and it might be as effective or more effective than some of our other agents, but with much faster recovery time. Nitrous oxide alone provides similar analgesia to topical anesthetic for IV placement. However, it's best tolerated when given together, and it might actually improve our success rate better than Midazolam for that utilization. So I said a couple times that nitrous oxide alone is not sufficient analgesia and sedation for very painful procedures like fracture reduction. However, nitrous oxide plus a co-analgesic strategy or hematoma block has been studied and looks quite promising as a potential sedation strategy. So here's a blinded randomized controlled trial of 100 children with forearm fractures. All of them got some oxycodone at triage, which was their protocol. And they were randomized to ketamine at 1 milligram per kilogram IV, plus a bit of Midaz, 0.1 milligrams per kilogram IV. And the other group was randomized to continuous flow, 50% nitrous oxide sedation, plus a hematoma block. And if you compare, both groups were very well analgesed. However, there was statistically less pain in the nitrous oxide plus hematoma block group and higher patient satisfaction scores. However, if you look on the right was the real difference. They had markedly faster recovery, 14 minutes in the nitrous oxide group versus 85 minutes in the ketamine and midazolam group. They were overall less sedated and had less adverse events in the nitrous oxide group as well. So there's a few other observational trials which seem to support the potential use of nitrous oxide plus hematoma block for fracture reduction. You can see the first study look at self-administered Entonox plus a hematoma block for forearm fracture reduction and found about 84% of children had excellent analgesic effect and 81% were amnestic of the procedure after. However, about 10% did not have adequate analgesic response to this strategy. So another group looked at what if we add in some transmucosal fentanyl on top of nitrous oxide plus a hematoma block, and they found a significant added analgesic benefit and a median pain score of 2.5 in that group for quite a painful procedure, forearm fracture reduction. Lastly, there was one group that said, hey, do we really need the hematoma block? What if we give some intranasal fentanyl and some high concentration of nitrous oxide? So they had a 70% demand valve system. And again, they found a median pain score of 2 for this, so very well tolerated in most patients. However, again, about 10% failed to have a sufficient analgesic response, so they had pain scores greater than 6, despite this strategy. So what's our take-home messages in terms of fracture reductions under nitrous oxide sedation? So nitrous alone is not sufficient sedation and analgesia for forearm fracture reductions. However, nitrous oxide plus a hematoma block and maybe plus or minus some opiate may be just as effective as ketamine and midazolam, but has significantly faster recovery and less adverse events. There's potentially even a role to avoid the hematoma block entirely with high concentration nitrous and intranasal fentanyl. However, we don't have this available to us, and about 10% of kiddos may not have sufficient analgesic effect with that strategy. So let's look at some adult data. So you can see here the AHS EMS protocols and nitrous oxide features quite prominently in the acute orthopedic pain and for procedural sedation. And I think it's unlikely that we're going to be using nitrous oxide widely for analgesia in the emergency department. Although I think it does make sense to understand what our pre-hospital colleagues are doing, why they're using this medication, and what our patients have had by the time they get to us. So here's a study in academic emergency medicine from 2013, randomizing patients to medical air versus nitrous oxide and oxygen at 50% for moderate to severe acute traumatic pain. And you can see no analgesic effect predictably from medical air, but quite a dramatic and good analgesic effect within about 10 minutes in the nitrous group. Pain scores less than 3 down to 2 out of 10. And then at 15 minutes, they gave everyone unblinded 50% nitrous oxide and again, excellent analgesic effect. How does this compare to some other agents we use, like fentanyl? So this is an ED-based study of 100 patients in Iran with X-ray proven extremity trauma like fractures and joint dislocations. And they either said, hey, here's a 50% Entonox tank, self-administer for analgesia, or they gave them 2 micrograms per kilogram of IV fentanyl. it's a pretty high dose. That would be like giving me like 180 microgram bolus of fentanyl. And you can see the pain scores. There was no significant difference in analgesic effect of nitrous oxide versus this high dose of IV fentanyl. Yeah, which is quite promising, at least in the short term. So given this knowledge, could we use nitrous oxide to reduce our gentleman with another anterior shoulder dislocation? So we know our pre-hospital colleagues, our ski patrol colleagues do this all the time. Is there any evidence that this works? So unfortunately, the evidence is highly variable and heterogeneous based on the shoulder reduction technique that they use. So all these studies looked at both primary and recurrent shoulder dislocation. You can see one early study of Coker's method, so external rotation method showed an 81% success rate with nitrous oxide versus 100% with IV morphine and midazolam. And then another study looking at the Milch method in 31 patients using continuous flow, 50% nitrous oxide versus intra-arterial lidocaine. And you can see that the success rate in the Milch method was 94% with nitrous oxide and only 73% in the intra-arterial lidocaine. And the nitrous oxide group experienced significantly less pain. So, you know, overall small studies, but promising results. Perhaps we can reduce 80 to 95% of these shoulder dislocations without the need for procedural sedation, second doc, RT, monitoring, recovery time, etc. However, they looked at this in a traction countertraction study using 120 patients in Iran, and they used either Entonox versus fentanyl and midazolam, and they had only a 10% success rate using Entonox and only an 80% success rate using IV sedation. So I think the takeaways there are, if you're using an atraumatic technique, it may have a role, but if you're using the old heel in the armpit technique, it's probably not going to provide you with sufficient sedation and analgesia. So the take-home points here are nitrous is a very effective analgesic for acute traumatic pain and for all-comers pain. To be honest, it's been studied in that respect as well. The efficacy may be similar to IV fentanyl in the short term. The evidence is weak and heterogeneous for shoulder reductions, but if you're using an atraumatic technique, it's reasonable to give it a shot. You know, I'll just say I put in 3 of the last 4 anterior shoulder dislocations that I've encountered with nitrous oxide, and I was just very impressed with how efficient it was, how good the analgesic effect I got was, and how quickly it was all over with no need for procedural sedation, second doc, RT. The patient was in the X-ray department getting their post-reduction film within 5 minutes and out of the department a lot faster. I will say the 4th patient I tried to use it on was methamphetamine intoxicated and quite psychotic, and he didn't take kindly to myself and the orthotech and the nurse all hovering around him and telling him to breathe in this gas. So you do need a cooperative patient if you're going to try this. So those were just a few potential applications for nitrous oxide, but if you can think of a brief, mild to moderately painful procedure, nitrous oxide might have a role for it. So you can see some of the other potential procedures, and most of which have been studied. So in and out caths, you know, paraphimosis reductions, foreign body removal, burn care, dressing changes, incision and drainage of abscesses. It's been studied in renal colic after an NSAID's been given and is quite effective. Refractory migraines, cardioversions, it's been studied in angina. There are a lot of potential roles for nitrous oxide in the ED. And I think once we have clinical experience, we can start to expand the use based on the procedure. So who can't we give nitrous oxide to? So despite the fact that nitrous is widely used in the L&D suite, there is concern regarding the potential teratogenic effects in animals. So it's contraindicated in the first and also the second trimester of pregnancy. The most significant contraindication is diseases of closed spaces. By that I mean pneumothoraces, pneumoperitoneum, bowel obstruction, severe bullous emphysematous disease, recent dives. So due to nitrous oxide's blood gas partition, nitrous readily passes into closed spaces 30 times faster than the nitrogen in air can escape. So it will cause expansion of pneumothoraces and bowel obstructions, etc. Lastly, nitrous oxide induces pulmonary vasoconstriction and is therefore contraindicated in severe pulmonary hypertension. So how safe is this medication to give? So I'm just going to give you the bottom line up front here. Nitrous oxide is a profoundly safe medication. There's one study of 3 million Dutch dental sedations without a single bad outcome. The main concerns are regarding diffusion hypoxemia. So because nitrous crosses the mucous membrane so quickly, when you stop administering nitrous oxide, it will rapidly diffuse out of the bloodstream and into the alveoli and can displace oxygen. However, this is more of a theoretical concern at concentrations less than or equal to 50%. Even at 70%, it's rare, although you would want to apply some supplemental oxygen afterwards if you were doing a 70% sedation. Vomiting is definitely the most significant adverse event. It occurs in about 2 to 8% in many of the largest studies, but it can be significantly higher if you combine it with other medications like opioids. Minor adverse events are extremely common depending on how you define them. So euphoria is probably the most common adverse event. There's also sedation, dizziness, headache, and dysphoria if the concentration is too high at times. However, these are extremely mild and self-limited and almost always resolve with stopping administering the gas. So just in case you don't believe me, here's a study of 36,000 nitrous oxide administrations, 80% peds, 20% adults. Minor adverse event rate was 4.4%. They had vomiting in 1.4% and serious adverse events in 0.08%. And only 0.03% were causally linked to nitrous oxide. There was no cases of laryngospasm, desaturation, aspiration events, seizures, or death linked to nitrous oxide. It was overall an extremely safe medication. So that was in all hospital-based settings outside the OR. How about specifically in the ED? So these are 760 children receiving 70% continuous flow nitrous oxide. So definitely the most aggressive strategy. And they had a minor adverse event rate of 8.3% with a 6% vomiting rate. And the serious adverse events were 0.3%. If you have a peak, one was a self-resolved chest pain after nitrous oxide administration, and the other was a desaturation event, diffusion hypoxemia after a 70% sedation, which resolved with oxygen. So getting to the end now here, is nitrous oxide safe for us to give? So it's considered a workplace exposure, and there's a couple of commonly cited studies of dental assistants suggesting possibly reduced fertility rate and increased miscarriage rate in dental assistants providing greater than 3 to 5 hours per week of continuous flow unscavenged nitrous oxide in dental theaters. So they were exposed to very high levels for very prolonged periods, and there was no effect in the lower exposed groups. I feel this probably has very limited relatability to the conditions we experience in the ED, but if the provider is pregnant, it may not be the best option for sedation. And then last couple of things, in terms of environmental safety, nitrous oxide is a potent greenhouse gas. It accounts for 6% of all US greenhouse gas emissions, which 98% are not medical related, but it traps heat 300 times more effectively than does carbon dioxide. And it reacts with stratospheric ozone, causes ozone depletion, similar to chlorinated fluorocarbons, which have been phased out globally due to ozone depletion. So that's something to keep in mind. And then the last thing is there an abuse potential for this medication? So people do abuse nitrous oxide. They can buy it legally as whipped cream chargers. They crack it into balloons and inhale it recreationally. It's called whippets or laughing gas. It's much, much more common in Europe in the rave and club scene. When bars get out, there'll be people standing on the street selling balloons. And prolonged exposure of nitrous oxide interferes with B12 metabolism. So abusers can get megaloblastic anemia, peripheral neuropathy, and worst case, flaccid paralysis due to subacute combined degeneration of the spinal cord. But however, this is not really an issue for our short-term procedural sedations. And it seems that abuse is not a big issue in Canada. So overall, the bottom line for nitrous oxide, so nitrous is a profoundly safe dissociative anesthetic with very favorable pharmacokinetics. It worked extremely rapidly, but it's not instant. So if you're using it for procedural sedation, you should probably give it, up to 3 minutes or so to take peak effect to optimize your success. Nitrous is available in our emergency departments. The optimal procedures are brief, minor to moderately painful procedures, or in combination with a local anesthetic to enhance the analgesic effect. The key for having success with nitrous oxide is picking the right patient and the right procedure. So my references. Happy to take questions if there are any. So I see a question from Aaron. Did any of the studies document the amount of nitrous oxide delivered? And if so, how is this measured? So mostly this is just documenting the fraction of inspired nitrous oxide and how they were actually administering it. So 70% continuous flow, 50% demand valve, like measuring concentrations inside the patient or CNS concentrations. Those have been done in sort of basic science studies, but nothing else beyond that as far as I know. Yeah, excellent, good question, James. I forgot to touch on this, COVID transmission risk. So according to AHS protocols, the use of nitrous oxide is not an aerosol generating medical procedure. You should definitely change the mask every time, and you should have a viral filter on top of it as well. But this is technically not an aerosol generating medical procedure. A question from Jason. Great talk. I feel I should be using this medication more often. What do you see as the barriers to more widespread use? Yeah, so I think the biggest barriers to using nitrous oxide in the ED is, for me, before, it was like a lack of knowledge. I just thought this medication, I didn't really think it worked well. I thought it was pretty much a pre-hospital or a dental medication. I didn't think that it had a great role for us. My opinion has changed since doing more research and using it clinically. It's actually very easy to get the nurses to get it for you, or the orthotechs to get it for you. And again, as per James's question, it is not considered an aerosol generating medical procedure as per AHS. Have had to look it up before. So, and then another question, this may be naive, med student, but why can't you use this in adults too? Absolutely, can definitely be used in adults. All of the pain literature and the shoulder reduction literature that I brought up shows it can be used in adults. Just most of the very best evidence is in pediatrics, and the best safety evidence is in pediatrics, but it has been studied in adults, including cardioversion. It's been studied for renal colic for patients that have had NSAIDs. It's been studied for refractory migraines. It has been studied in adults, and it's very reasonable. I think it makes our patient experience better for very brief, painful procedures. I think that's all of them. Okay, the emergency SCN is producing a new provincial protocol for nursing to use Entonox within the ED settings and in conjunction with labor and delivery. I'd like to share our latest draft with you before we move it to the next step. Love it. Yep, there is a few good studies looking at nurse-initiated Entonox in the emergency setting, and I think it's extremely favorable, and the safety profile is good, such that nursing can have this medication administered, particularly if patients self-administer. So if they're holding the mask on and they become over-sedated, the mask is going to fall away, and nitrous oxide will not flow anymore, and they'll become less sedated. So it has a built-in safety mechanism if they self-administer. So yeah, awesome to hear that. From Connie, we just use it in our ED, but it is done in a PCA form for delivery. The patient has to be able to hold and comply for taking it in their own dose. Yeah, very reasonable. Like I said, that's how it's administered in the pre-hospital setting. That's how most nurse-initiated protocols use it. And it is a built-in safety mechanism. If they can't administer anymore because they're too sedated, it's going to fall away and they're going to immediately become less sedated. If you're doing it for deeper sedation or like the continuous flow studies, obviously they're not holding it on their own face. They have it as a mask. So yeah, I think that's a very reasonable option. I think that's it. If we want to switch over to Tara's.
Great. Thank you so much, Ben.